My name's Dr Melanie Stephens. I work at the University of Salford, and I'm presenting for the next 20 minutes about conducting a feasibility study and a longitudinal study exploring the impact of interprofessional education in regards to student training in care home environments. As you can see from the slide, I was part of a really fabulous research team, but also I do have to give due regard to our fantastic partners across the 4 Greater Manchester universities, our huge Greater Manchester clinical placement network, placement leads and programme leads, who without we wouldn't have been able to conduct this study. And there's pictures of the 5 care homes involved. 4 were care homes with nursing, and 1 was a care home which was residential. So we have Heathlands, Lakeside, St George's, Belong Atherton, and the Old Vicarage in Bolton. So hopefully in the next 20 minutes, we'll explore what I mean by interprofessional education and why we might need it, what the model was like in the care homes where we conducted the study, and then share and discuss the findings of the feasibility study and the longitudinal study, which we call a repeated measures design. So when we think of IPE and where it is usually conducted, we usually think about integrated teams. We also think about qualified and registrants rather than students, unless we read the literature where IPE is about students learning from with and about each other to improve the quality of care and improve their collaborative learning skills in ready for registration. However, at Salford, what we recognised is that when we talk about the term professional, we actually omit a group of people who wouldn't consider that their role in a collaborative environment as a profession. They might be a patient, a resident, a service user. They may come from an occupation that's a discipline rather than a professional background. So in 2013, we changed our definition of what IPE is to this statement in front of you on the screen. So you can see that it talks about being a group of people. We can be from different backgrounds, but we work and learn together. And this is to ensure that when we plan and we decision make and we take into designing something or providing a service, whether that's for a child, an adult or an older person, that we consider them in that almost like George Engel's biopsychosocial model. So we're thinking about the whole of the person and the whole of the team. So what is IP and where is it usually conducted? Well, if we look at our colleagues from Scandinavia, in particular places like Sweden, Norway and Finland, IPE is usually found in clinical settings. And when I mean clinical settings, we're thinking about wards and departments, usually in healthcare services. We're very fortunate that our colleagues in Linköping in Sweden have been conducting IPE with students in orthopaedic units, in particular in orthopaedics rehabilitation, for the last 25 to 30 years, and have really demonstrated the rigour and robustness of why it's important to bring students together so they're ready for integrated practice and qualification. However, what we did is we looked at the literature. We did something called a scoping review, and it's due out for publication very soon, where we wanted to examine the research about, well, what about IP in care homes? Is there any literature around that, and what is the effect? So what we found from doing this scoping activity is that actually it allows students to understand different caring practices than what they would see in healthcare services. It improves their social connectedness. So what is meant by that is intergenerational learning between older people and younger people. And also students became skilled and knowledgeable in the speciality of aged care practice, because usually in care homes, students will work with older adults. But what we found from this review of the literature is that there were very few studies investigating IP in the UK care home environment. And actually, most of the focus in the studies was on outcomes pertaining to student learning and their development, and not really on the organisation who was housing this IP activity, nothing on the staff, and very little on the residents. So we thought, well, there's a gap. We could start to think about how we implement IPE in the UK care home environment, but look at 3 different groups of people. So our aims and objectives was then to develop a scheme, an IPE scheme, and investigate, first of all, the feasibility. So do a small study, let's do a test of change. And then if that works, take what we've learned from that and then look at a longer term impact with more care homes. And we wanted to do that across Greater Manchester because obviously working at the University of Salford, it was an area of interest, and we wanted to look at the experiences of 3 groups of people. The students who were placed in the care homes to participate in the IPA experience, the residents who agreed that they would work with the students in the IP activity, and also the staff members, not only those who were part of the IP activity, but also worked around the students as well, helping them learn about what it's like to work in a social care environment. So as you can see, our objectives were to develop and evaluate these, what we call cycles, and I'll talk about them in a few minutes, of this IP initiative, and then measure, evaluate and understand the impact on staff and on students, in particular their knowledge, their skills and personal development. And then asking the residents, what was their experiences of care? And then finally to disseminate any key learning, best practice, and hopefully see this as a model of good practice going forwards for other HCIs and the health and social care sector. Within research, we always use something called methodology, not the methods of data collection, but the approach we're going to take to conducting research. So we felt it was really important that we were a collaboration. So Heron's cooperative inquiry is this approach, and it's all about doing research with people rather than on them. So it was really important that we had a steering group, a core operational group and a care home support network. And the reason for this is that we wanted to reflect the environment and the people who would inform the process. So the steering group included different members across the whole of Greater Manchester who had senior positions in health and social care, and we were lucky as well. Dr Mervyn Eastman also was on our steering group because we wanted someone who was older but had significant knowledge and experience, especially as his role previously as the Director in Social Services, to really give us a critical friend in the process. Then our core operational group, so this was support with on-the-ground implementation. So again, this was about programme leaders from the different programmes of different professions, placement leads, practice education facilitators who support the care homes and the students, and lots of other people, our research team as well. And then finally a care home support network, because what we wanted to do is meet regular with the care homes involved to ensure that they felt supported and they had a collaborative space where they could reflect about implementing this IP model and then helping us with the evaluation arm of the work. So as I've said before, the 5 care homes involved were Lakeside in Wigan, Heathlands in Prestwich, St George's in Wigan, Belong in Atherton and the Old Vicarage in Bolton. And we tried to get a wide spread of different types of care homes with nursing, residential homes, care homes that were took residents with advanced dementia and others who had a real mix of adult population, because we wanted to not have a homogenous group, we wanted heterogeneous groups, so a real mix of kinds of care homes, number of residents, numbers of staff, to see how it worked in each kind. So really, really important. And then we had to then think about, well, how are we going to get students into the care homes and how we're going to deliver these this IP scheme. So we had to sit down across the 4 universities of Manchester and look at all the 36 programmes of different types of students, from nursing, sports rehab, physio, OT and dietetics, and then look for periods of overlap. So students could be on placement in the homes from anything between 6 to 18 weeks, depending on their programme, and we would look for the periods when there was overlapping. And we wanted to provide 6 weeks of overlap because my previous PhD studies, I examined how we actually start to change attitudes and values of students using IPE, and I found that 6 weeks seemed to be like an optimum time for my PhD, so that helped inform this process. So as you can see, these are from June the 5th 2023 to December. So this is the longitudinal study where we implemented 4 cycles of IPE from students across 3 of the universities, and the students, we situated 2 or 3 students in each of the homes for each of the cycles. So as you can see, we might have had students from mental health nursing, sports rehab and dietetics, or OT, physio and learning disability nursing. So it's a really nice mix of students. So the students would be there on either full-time placement, so they would be there all the time, usually nursing students, or the allied health professions and sports rehab students tended to be there on a part-time basis. So they had something called a split site placement. So they were with perhaps a community service or a hospital service, and then they would come to the care home for 1 or 2 days, and then they would participate in the IPE scheme. We then each week held, during the 6-week overlap, something called multidisciplinary team meetings. And we called them that word because initially we were going to call them action learning sets, but the care home manager specifically said action learning sets made it think it was too academic, and they felt that that would put them off and put students off. So we called it an MDT because students were cognizant with those words in clinical practice, and so were the care home staff. But the whole purpose was to foster interprofessional development, and also the purpose of action and then reflection. So the students would meet weekly to work in this MDT to address the residents' goals, and we use the process and principles of action learning. So on week 1, the first week, there would be students, care home staff and a meeting facilitator, and that would be an academic from the university. And the academic was there to train up the care home staff to become future meeting facilitators, so they wouldn't need us anymore, because the purpose was for this project to be sustainable so that we could carry on offering interprofessional placements in the future. So that first session, we would introduce the students to each other, to the care home staff, to action learning, and then they would meet the residents, and the residents would attend the meeting separately for confidentiality reasons. And in the first meeting, the residents we'd put up posters to advertise their participation in the project, would come, talk to the students a little bit about themselves, say who they are, why they'd moved into the home, a little bit about their family, about their life, and then they would talk about what the goal that they wanted the students to help them achieve. And that could be anything from walking for longer, helping with the diet, because this gentleman was diabetic, and he felt that the diet, the dessert menu in particular, wasn't cognizant with wasn't good for somebody who's got diabetes, and it could be other things like support with social activities. Lots of people had played sport in the past, or danced, or had different physical activities and could no longer do them, or felt that they could no longer do them. So it was support with those social activities. So on week 1, they would meet the resident, and then we would ask them questions. We would ask the student questions. We would say, well, now you've met the resident, you know what the goal is. What do you think you need to know about them before you can start to work with them on this goal? So usually week 1's actions were all about going and spending some time interviewing the resident and getting to know them, going and meeting the staff who care for them, going seeing the home and seeing what services and what care is provided and who works in the home, and then going reading the residents' notes, looking at the medical comorbidities, any medicines that they're on, any equipment they use. And they would come back in week 2 and present what they found about the resident. So then we would then say, well, okay, you found out all of this about your resident. How will that information help you with planning some interventions to help them achieve that goal? So each week it was about giving them actions and reflections so that by week 6, the students had helped the resident either fully or partially achieve the goal. They will also then have some fantastic presentations about the resident, and usually unearthed information even the staff didn't know about the residents. And then write a care plan, a collaborative care plan to help that resident continue with the activity or the intervention. So, for example, the gentleman with diabetes who wanted to change the dessert menu, what they found out throughout the weeks was it wasn't that the home wasn't providing desserts for people who are diabetic. It was his knowledge from being a diabetic for a very long time was situated in the 1970s and not in current day practice. So the students learned all about motivational health interviewing and coaching, and how to then help him think about what is considered healthy in a 2023 lifestyle. One of the gentlemen, his goal was to play his accordion at a concert for other residents with his brother. When they first met him, they got to know that he had early onset dementia, wasn't in the right wheelchair, was in a slump position, so he wouldn't even be able to sit up to play his harmonica. So by the end of 6 weeks, they'd learnt all about what dementia is, seating position, getting the right wheelchair and the right chair for his room, and then helping him put on his concert for other residents at the end of the 6 weeks. So there was some really lovely principles of action learning, but the students went away and worked together on these activities to really think about their actions and interventions and their decision making, and they were supported by the care home staff to do this. So really, really important for us is not only did we want to implement the scheme, but we wanted to evaluate it. And we did 2 methods of evaluation, a mixed methods approach. We had our quantitative data. So we developed a digital survey from the feasibility study because we wanted to capture the impact of the students and the staff being involved in the initiative, and had it developed any knowledge, any skills, or had it developed them personally as a professional, as a student or a registered nurse. And then we had an open-ended box underneath each weekly digital survey to capture further information. So if somebody said that actually this week I'd had major positive impact on my knowledge from participating in the IPE scheme, we'd ask them to complete in the open-ended box. So what kind of new knowledge was that in particular, and can you expand on your answer? And then we also had qualitative data collection. So we conducted some interviews with a smaller sample of care home managers, care home staff, some residents, and one student from each of the professions that were represented across the scheme. So I'll present the qualitative findings first. So what did we find through knowledge, skill and personal development? Well, across both students and staff, we know that being involved in these weekly MDT meetings as part of an interprofessional team, there was this sharing of knowledge across different diverse healthcare professions, and the students learning all about social care and what happens in social care. We found statements from staff and students that the IPE scheme fostered these broader professional skill sets and clinical skill sets, so they learned more about physiotherapy, about occupational therapy, sports rehabilitation, and how that can help personalised care for the residents who were involved. There was lots of feedback from students in particular about personal development, that they learnt more about reflective practice, what person-centred care really was. We got lots of feedback from students that they thought they understood person-centred care, but actually what they saw being given to residents in care homes definitely was person-centred, and that they'd actually been focused on tasks in their health care environments because of how busy it was. The students also talked about they gained confidence and actually these embedded perceptions. So many students talked in week 1 about not wanting to come on this placement. Why have I been given a care home as part of my placement circuit? I'm really not happy. I think it should change. To the end of the placement where they were saying that they didn't want to leave. Could they stay for longer? Could they come back at a later time? And a really lovely statement here from a physiotherapy student about working with a student nurse closely and how they filled in each other's knowledge gaps. And it was really important to, care delivery. We also then wanted to look at what the long-term impact had been for the care homes who'd had these repeated cycles and students coming in and then leaving and coming in again. So they said that the framework actually was really valuable as a placement kind of model. So instead of students being allocated to them, doing an induction, and then the students shadowing staff or being given some residents to work in a uni-professional way, actually this was valuable because it gave structure each week to placement and actually structure to activities that the students needed to complete during the whole of the placement. So they said that that was really beneficial to them as a care home team. They also said they were really pleased that they then learnt to facilitate the MDT meetings. So the staff had gained new knowledge and skills in being action learning set facilitators. And then there was quite a lot of feedback about new techniques being introduced into the home, new equipment, new guidance, and lamination of a lot of techniques or exercises or activities for the residents, which were kept in the room on the wall so that it could be continued by the care home staff. And then obviously what was really important is, well, how did the residents feel participating in the IP care home scheme? What was it like for them? The residents talked about this real heightened sense of well-being from being actively involved in decisions about the care. They felt that they got some meaning and purpose, and the residents talked a lot about giving something back to the future health and social care professionals. They were helping them become the best nurses, physios, OTs of the future. But they also felt they benefited from this intense period of holistic and personalised approach to their care. And you'll see on the left a quote. This is from one of the residents. She'd been discharged from hospital, and it was surmised that there really wasn't anything else that could be done for her in regards to her mobility, that she would really just be able to transfer from bed to chair going forwards and need a wheelchair to be ambulant. So her goal was really just to start to improve her mobility. So in week 1, she was bed to chair transfers. By week 6, she was actually walking with a gutter frame throughout the home. And you can see here that she makes this statement that they let her be free, that she became free. And there's a really lovely video of this lady. She's on the Greater Manchester Social Care Learning Environment website. She agreed to be videoed, and she talks about how she's really it's really helped her significantly, and also what she has done is now she works with the activity coordinator and gets some of the other residents up and physically active, because she's saying that look what happened when I participated, the positive impact on me. We also then obviously collected this quantitative data, because we asked the students and staff to self-report what positive impact had there been on their knowledge, skills and personal development. So what we did is we collated all the means from week 1 right through to week 6. And as you can see here, there's been a change from week 1 of knowledge to week 6. Same for skills and for personal development. And then we ran the data through something called SPSS, which is a data analysis system, and we used something called paired t-tests, and we wanted to find out, is there a difference between mean scores from week 1 to mean scores in week 6, and whether then we could say that being involved with IPE had a significant effect on student and staff's knowledge, skills and personal development. And what we can say is they were statistically significant. It didn't happen just by random chance. Actually, by participating in an IPE scheme like this in a care home environment will lead to knowledge, skills and personal development of staff and students. So for us, it supported the qualitative findings that we'd collected through the interviews. We did learn a lot of lessons. It's not been plain sailing. It's not been really easy to implement. And the way that the IPE model fits in each home looks totally different, because it's not just about the size of the home, but it's the residents who live there, the staff who think about their residents and what their residents need and which students would be most appropriate and when they should have these opportunities for students. Because again, we all know that when you have students a lot, it can be emotionally labouring. So we've got to think about rest. We then also think about facilitating factors and this process of learning, action learning. So in the first cycle, the academic staff ran the action learning sets. In the second cycle, the care home managers ran the action learning sets, supervised and supported by the academics. And from cycle 3 onwards, everybody was left to carry out them themselves because they were so competent and proficient. We did have obviously lots of jigging around with allocation processes, but we've now got that sorted of when students go out at certain periods of time across all these modules and programs, and then looking for the periods of overlap. And then for some students, especially allied health professionals, they need something called long-arm practice supervision. If there's only registered nurses in the home, then they're going to need somebody from their own profession who offers that long-arm practice supervision. So we have written a scoping review paper on that. We're releasing our Greater Manchester guidance next week for physiotherapy, because we've already got them for OT and for social work and for nursing. So we've learned a lot about how do we safely long-arm supervise students. And we also learned that just students having a one-day placement as part of the IPE model, it doesn't work. We need students to really understand the culture of social care, develop therapeutic relationships with the residents and the staff. So we say it's a minimum the students should be on placement 2 days a week for a 6-week or longer placement, because it's important they develop those fantastic relationships and really get to internalise what it's like to work in a care home environment and feel part of the team. And as Ted Rogers said, you might not know this programme, it was a programme called 3-2-1 with a dusty bin, and if you were very rubbish at quizzes, you got a dusty bin at the end instead of a big prize. Well, you might think you're at the end of something and then you're at the beginning of something else. So this is about sustainability. 4 out of the 5 care homes are now continuing and have continued with the IP programme. One of the homes couldn't for certain, there's many complex reasons. And now we're trying to work closely with the ICB, across the universities to scale up, because lots of care homes have come forward and said, we'd love to have students. It gives us an opportunity to bring in professions that it really takes a long time for them to come in, unless you work in an area where there's a group that's specifically meant for care homes and their support. And also because there's a change in careers. One of the care homes in particular now has employed an occupational therapist because they saw the value from the students being on placement with them and the value to their residents. So if you think of you want any, I'm happy to share the slides. I can send you the website with all the details on all our resources. And it's actually on the slides themselves. And we're just waiting now. We're submitting an NIHR Stage 2 application to actually roll this out across the whole of England. So we're hoping that we are successful and we can do this on a national scale. So I'll stop sharing and happy for any questions.
Fabulous. Thank you so much, Melanie. I'm going to take you off spotlight for now because we are such a small group today, so we can see everybody. And I think it'd be better for you as well to see everybody rather than just have you on screen large. Thank you for sharing your contact details, because that was one of the questions that I'd written down to ask you, was how can care homes get involved in this IEP programme? So they can contact you. As you said, you're looking at running it out nationally. Do you have a time frame for that?
So we've got 5 universities working with us, and each have got 3 care homes. So we've got 15 care homes. So we've to submit our stage 2 by the end of November, and then hopefully in the new year we'll hear something about that. But if anybody else is interested, I've been meeting with organisations who are particularly interested in rolling it out for them. So I'm quite happy to meet separately to have those discussions and those initial, tentative steps of what's needed.
Fabulous. Thank you for that lovely offer. I would like to hand over to our audience at this point and invite any questions that you may have. We've still got Gemma, Chloe, we've got Amy, and we've got Igandan on the call as well. I think that's your first name by the looks of how the other delegates have come on the call today. Please correct me if that's not right. We got any questions from our audience? Yes, Amy, please do unmute, yeah. Oh,
sorry, I'll try and put my camera on. So, hello, hi.
It's lovely to see you. Hello.
I'm Amy. I'm one of the consultants in paediatric intensive care and adult intensive care. That's a fantastic case study. I'm really inspired by that. I think one of the passion that I have, it's obviously with education and quality improvement. So I only know sort of PDSA, kind of, sort of doing QI, and I always, start small rather than trying to change the world. So, you've captured all that really nicely. But just listening to you also really inspired me on thinking about how we get feedback so that we know how to improve, the education. It's not about the individual, because I think for me, certainly that's one of the struggles I have, because obviously I run a lot of courses for doctors. But my interest in team build, interprofessional teamwork and everything, trying to get doctors and nurses to attend the same course, because obviously because of our licensing, and appraisal, we all have different objectives. But I really like, I think I've sort of made notes about some of the principles. So hopefully I can try and bring, think about on the feedback one, for example, what's the impact on the organization? Because a lot of time we say, what's the impact on you? Oh, I learned this, but actually, what does it mean in your workplace, but also to your team member as well? So, yes, I just want to say thank you very much. That was really good. Thank you.
Thank you. Thanks, Amy.
Igandan, is that correct? Am I saying your first name correct? It's not your surname?
Well, my first name is Ayodele.
Ayodele. I am so sorry. It's just everybody's coming with their first name first today.
That's right. Thank you. Yes. Thank you so much for this. When I saw it, I saw, this is how to go in this era where we try to remove any kinds of silo working, or just to encourage interprofessionalism. Because the patients, the service users, they are a whole human being. There's no point separating an aspect of their life from the others. And when professionals work together, they get better outcome. By training, I'm a social worker, and I currently also run supported accommodation for people with learning disabilities. And I do some teaching, some academic work part-time. just to, a kind of a sessional lecturer in one of the universities. So that's kind of a kind of background. So this is really coming home to me, and it's something I really, because the opportunity for students to learn, also to demonstrate and empower my team members as well, and for better outcomes for the service users. So I think it's something that yes, I will be sending you an email, and so that we can see the area of the cooperation and whatever we can do together. Thank you.
Thank you. Oh, that's fantastic, because I was some of my concepts initially came from spending some time with colleagues in extra care and assisted care, where people were just supported to become to live independently. So actually the social work model actually has a huge impact on this, and also some other work. I was very fortunate to go to Nijmegen out in Holland to actually see something called a recovery hotel. They're really, really inspiring places where people stay in hospital for a very short period of time, go to the recovery hotel, which is mainly run with students and very few registrants, and they deliver the care because it's about empowering people to take ownership of their own health with the support of students. So they use these communities of practice to help students learn about integrated working, but also people to get better as part of a rehabilitation. What they found is when they called it a hotel, it's just a funny story, lots of patients went there and relaxed and thought they didn't need to do anything. So they changed the name to a recovery centre so that patients would know that they're there to get better, to go home, not to stay and have saunas or massages off students. But really, really good stuff. That's where it actually started from.
I picked up your point earlier on, actually, Melanie, about the use of action learning sets being academic, so that they, you changed the name to MDT, wasn't it? Multidisciplinary meetings for teams. I think that's really interesting, the use of language and the conceptions that people have about that as well. Something to consider when these programs are upscaled nationally, and how they are pitched. Just something I thought I would mention off the back of Ayodele's comment there. Thank you.
Yeah, and it is so important, and that's why Heron's cooperative inquiry was part of the approach taken, is that we've got to use terms that everybody's happy with, and that they'll use, and it's natural and it's not forced and they feel comfortable with. And yes, action learning is a process of facilitation, and it moves from being didactic. So instead of it being the instructor and knowing everything and telling the student what they need to know, actually it allows the student to become independent and have to learn everything for themselves and problem solve with support. And then they learn more. We know that it leads to deeper learning instead of surface learning, and actually leads to real change. So it's almost like the principles of work-based learning and independent study. Really, really important for the students.
Definitely. Thank you. Gemma or Chloe, would you like to ask a question while we've got Melanie today? No? Oh.
I don't have a question necessarily, but I just want to say thank you. It was a really fascinating project that you're working on. I'm a frailty CNS at Royal Sussex County down in Brighton, and we're currently working on pathways with our patients, looking at sort of pre-hospital admission pathways, so looking to work with our care home matrons and our community partners in developing pathways that really support care home residents in having care in the place that best suits them, whether that's hospital or at home. So this is a really interesting kind of way of looking at it, and I've never looked at it from a student perspective. Actually, we did IPE when I was at uni, but we don't really do a lot of interprofessional learning now, and it's so important to have that real MDT approach to patient care. So no, I'm really grateful for your time. Thank you so much.
Yeah, no, thank you. And I think the lovely thing about students is they make you think differently, because they bring up things that perhaps when we're working full time in practice, we haven't had a chance to read, haven't had a chance to be introduced to. But but also then as a clinician, you then can go through your thought process of clinical decision making and clinical reasoning. So, for example, one of the two physiotherapy students, a mental health nurse and a dietetic student, were working with a resident who had significant arthritis in her knees. And they went away and read all the different systematic reviews and all of the interventions and brought them back the week after to present. These were the interventions they were going to explore. And we actually invited the long-arm supervisors along as well. And it was really interesting because each time they said, well, we want to introduce this intervention, and they'd explain really well the appraisal of the literature as well, which was fabulous. So they were really bringing theory and practice together. And then the clinicians would go, well, that's not going to work because, and they would explain why. And they got through 4 different interventions and they said, we're really sorry, but this is why that won't work. However, you've brought this tiny bit of information we didn't know. Let's try that instead. And it was really good for the students. Finally, they thought, oh, 4 interventions, we're never going to, what are we doing this work for? And then a tiny intervention that they paid due regard to then became this activity for this lady, which led to her improving her mobility with her knees. But it was really interesting that, for them to understand that. So, I think it's great. And it's great for the care home staff because then they got to hear about evidence-based practice. Not that I'm not saying that they don't do evidence-based practice, but different evidence-based from different professions than their own, and made them think differently. So really clever. So, for example, the dietetic students, they were trying to increase in one of the homes fruit and vegetables into the diet of some of the residents. They were older. I'm old, I'm 80, I don't really want to eat those anymore. I've got capacity. So they did a smoothie tasting afternoon and put loads of different supplements in, because they knew they were working with the physio and the sports rehab, that they needed to get more fruit and vegetables and also supplements to improve their immune systems, and also extra protein for some of the activities they were getting involved in, some more physical activity. So the residents were like, oh, this is fantastic, and we'll keep these ones. So it introduced new concepts into the home as well, about thinking differently about diet and supplements. So great ideas.
Brilliant. Fabulous. I think having your passion and your team's passion as well has been a great driver in this initiative. It's clear just today and how you've told us about the approach to it and how you've seen the results come to fruition as well. So thank you so much, Melanie, for sharing that with us today. I've given the audience the opportunity to ask their questions, share their comments. We have got the recording to share as well for those that weren't able to join us live today. Melanie will be sharing her slide deck with us, so you'll receive a copy of that as well. But I will give you all 15 minutes back of your day. Thank you, Melanie, for your time, and we hope to see you at another IHSCM event soon. Enjoy the rest of your day, folks. Take care. Bye.
Oh,